Okay, imagine this. You're maybe playing with a new kitten, right?
Yeah.
And you get this tiny little scratch, barely notice it.
Uh-huh. Happens all the time.
Then maybe a week or two later, you feel this, I don't know, lump, swollen gland under your arm, maybe in your neck, and it just doesn't seem to be going away.
Right. Yeah. What's going on there?
Exactly. Well, that seemingly innocent scratch could actually be the start of what we're diving into today. Cat scratch disease.
Also known as cat scratch fever.
Precisely. And this deep dive is, well, it's specifically based on material provided by you, the listener. You send us your detailed MSRA revision notes on this topic.
Yeah, so our mission today is to take all that crucial info, all those facts and figures from your notes, and sort of break it down, make it really high yield, easy to remember for your exams.
Think of us as your revision buddies for this session. We're aiming to navigate these specific notes, pull out the absolute must-know points, and hopefully make some connections that help it all stick.
We'll be covering everything laid out in your material, really. From, the bug itself right through to the long-term picture.
Yep. We'll unpack what it is, the cause, the risks, how it actually affects the body, what other conditions look similar. That's a big one.
Definitely. And who gets it, what the symptoms are, how doctors figure it out, the management approach based on these notes, and then prognosis, complications, prevention, the whole lot.
Okay, let's jump straight in. The absolute basics first. What exactly is cat scratch disease?
Okay, so fundamentally it's an infection caused by a bacterium, a specific one called Bartonella henselae.
Bartonella henselae, right. So the name CSD points us to cats, but this is the actual microscopic culprit. And how do people get it?
Well, the clue is in the name there. Humans usually get it from cats, typically via a scratch or sometimes a bite from a cat that's carrying these bacteria.
So the key things are a cat, a scratch or bite, breaking the skin. And this specific bacterium, what does it mainly do once it's in?
The primary target, initially anyway, is the lymphatic system. The bacteria find their way to the lymph nodes near where the scratch or bite was.
Ah.
And that triggers an inflammatory response. That's what causes the characteristic swelling, the tenderness in those nodes. Usually for most people, symptoms are sort of mild to moderate, really centered on these swollen glands.
Right. So a really key takeaway from your notes right at the start, think of that triad. Cat contact, scratch, or bite plus Bartonella henselae equals swollen lymph nodes nearby. That's the classic picture.
Spot on.
Building on that then, let's look at the etiology, the specific cause and spread.
Yes.
We know the bug is Bartonella henselae.
Right. Now, where does this bacterium actually hang out and how does it get passed around?
Good question.
The main reservoir is cats. And your notes really emphasize it's particularly common in kittens and also stray cats. The bacteria live in the cat's bloodstream, but importantly, they're found in high concentrations in their saliva.
Ah, saliva. So that makes sense why scratches are so common. Then the cat licks its paws, gets bacteria on the claws.
Exactly. And then scratches you. While scratches and bites are the main routes, your notes do mention transmission could potentially happen through contact with fur, too.
Really? How?
Well, especially if there are fleas involved or maybe tiny breaks in your skin. The bacteria are in the saliva, and fleas can spread it between cats and potentially contaminate the environment or fur with flea dirt containing the bacteria.
Okay, so fleas are part of the picture too.
They definitely seem to be involved in the cycle between cats, so a key insight for etiology. Think kittens and strays often being the source, and the bacteria hiding in saliva spread via claws, bites, and potentially involving fleas. Humans are sort of accidental hosts.
Right. Let's talk risk factors then. Who's most likely to get this?
Well, the most obvious risk factor is simply close contact with cats, owning them, playing with them frequently, and linking back, especially contact with kittens or strays, as your notes highlight.
And here's something crucial from the source material you sent. The infected cat often looks perfectly healthy.
Absolutely vital point. They can be silent carriers. You wouldn't know just by looking at them.
So that's the risk from the source, the cat itself. Are there human factors that increase the risk of getting ill?
Yes, your notes are very clear on this. People with weakened immune systems are at higher risk. So, individuals with HIV/AIDS or those on immunosuppressive drugs for other reasons.
Okay, so for risks, it's kind of two-layered, isn't it? There's the exposure risk, what kind of cat contact you have, and then the host risk, your own immune status.
Exactly. And being immunocompromised really increases the risk of the more severe forms, which we'll get to.
Right. Let's trace the journey now. Pathophysiology. How does it all unfold once the bacteria get inside?
Okay, so Bartonella henselae gets in, usually through that scratch or bite, breaching the skin barrier.
And then it's got an entry point.
Precisely. It hops into the local lymphatic vessels right near the injury site, and from there it gets transported along to the nearest regional lymph nodes.
And that's where the action happens, the lymph nodes.
Yes, that's the main battleground, you could say. The bacteria start replicating in the lymph nodes, and this triggers a really strong inflammatory response from the immune system. That's what causes the swelling, the tenderness, the pain.
But it doesn't always just stay contained in those nodes.
That's right. While the nodes are the focus in most typical cases, the bacteria can sometimes spread from those nodes into the bloodstream.
Okay.
And that's how they can potentially reach other organs and cause those more widespread systemic symptoms we mentioned.
So the sequence is sort of entry lymphatics, local nodes, multiply, inflame, potential spread, immune response tries to control it.
Correct. The immune response is crucial for getting it under control eventually. Although, as we'll discuss, those swollen nodes can hang around for quite a while, even after the infection itself is dealt with.
Okay, so the key pathophysiology point. It uses the lymphatics to get to the nodes, and that's why swollen nodes are the classic sign.
Exactly.
Now, this is often a tough area for exams. Differential diagnosis. Those swollen lymph nodes. What else could they possibly be?
Ah, yes. This is where good clinical detective work comes in. Your notes rightly point out that telling CSD apart from other things is vital because, well, loads of conditions cause swollen lymph nodes. Bacterial, viral, even non-infectious things.
So how do you even begin to narrow it down when you see that symptom? It seems overwhelming.
You go back to basics. It's all about the clinical picture, the other symptoms combined with a really thorough history, especially asking that key question about cat exposure.
Yeah.
And then you use lab tests to support your suspicion.
Right. And the list your notes provide. Wow. It really shows the breadth of possibilities. Things like other bacterial infections, brucellosis, Yersinia pestis, that's plague.
Yep, plague. Also tuberculosis, tularemia, syphilis, all on the list.
In viral causes, too, like glandular fever, infectious mononucleosis, tick-borne diseases, and systemic things like sarcoidosis, lymphogranuloma venereum, toxoplasmosis as well.
It keeps going. Atypical mycobacteria, lymphoma cancer, obviously collagen vascular diseases, chronic granulomatous disease, simple pyogenic lymphadenitis, fungal infections like histoplasmosis, sporotrichosis.
Blimey. That is a lot of potential mimics.
It really is, and that's the takeaway here, isn't it? Swollen nodes are common, but the cause might be rare or unexpected. The sheer length of this list just hammers home why taking a detailed history, asking about animals, travel, other symptoms, everything is your most powerful first step. It helps you navigate this minefield before you even think about tests.
Absolutely crucial point. Okay, moving on to epidemiology. Who gets this and when?
Well, cat scratch disease is actually pretty common, found all over the world.
And the notes mention specific groups it affects more often.
Yes, it's seen more frequently in children and young adults, which, again, makes sense, doesn't it? It ties back to the risk factors. These are often the groups having the most hands-on contact with cats, especially playful kittens.
Makes sense. Is there a seasonal pattern mentioned? I know these notes might be UK-focused.
Yes, the source notes do say that in the UK, CSD incidence seems to peak in the autumn and winter months.
Huh. Any idea why that might be?
Well, the notes speculate a bit. Maybe links to cat breeding seasons, meaning more kittens around in autumn. Or perhaps just people spending more time indoors during colder weather, increasing close contact with their pets.
Could be either, I suppose. So, epidemiology takeaway. Think young people plus cats, and potentially more common in autumn-winter, maybe due to kittens or more indoor time.
That's the gist of it from the notes.
Right, let's bring it all together now.
Yeah.
Clinical presentation. What does CSD actually look like when someone has it?
Your notes describe a fairly typical timeline. Usually starts where the scratch or bite happened.
Yes, the initial lesion appears, 3 to 12 days after the contact, especially with kittens or flea-infested cats, described as a small red bump or blister.
And an erythematous papule or pustule, yeah, often gets a bit crusty, can be quite subtle, easily missed.
So that initial spot might not even register. The thing people usually notice comes later, doesn't it?
Exactly. The hallmark symptom, the lymphadenopathy, the swollen glands that develops later, typically 1 to 3 weeks after that initial lesion, the lymph nodes draining the area of the scratch swell up.
But where do these nodes usually swell up? Common sites.
Your notes list the most frequent ones, the axilla, armpit, cervical nodes in the neck, and inguinal nodes in the groin. They can be quite painful, tender to touch, and sometimes they can even separate, form pus, like an abscess.
Okay. Beyond the local spot and the swollen nodes, are there other general symptoms?
Yes, systemic symptoms can happen, maybe not always, and perhaps more common if someone's immunocompromised. Things like fatigue, headache, maybe a low-grade fever, feeling off your food, loss of appetite.
Got it. Your notes also go into quite a bit of detail on the more severe or atypical forms. Sounds like these are rarer but important not to miss.
Definitely rarer, but crucial to be aware of. These usually involve the infections spreading beyond the lymph nodes. The notes list things like bacillary angiomatosis, these sort of vascular skin lesions, almost exclusively seen in immunocompromised patients. Then there's aseptic meningitis inflammation around the brain. Parano-oculoglandular syndrome, that's if the bacteria get in the eye, causing conjunctivitis and swelling of nodes near the ear. And neuroretinitis inflammation in the eye affecting the optic nerve and retina, which can cause vision loss.
Serious stuff. Any others mentioned?
Yeah, a few other rare ones.
Right.
Significant tummy pain, which might be linked to the liver or spleen getting involved, hepatitis or splenitis. Osteolytic lesions where the bacteria infect bone. Erythema nodosum, those painful red lumps under the skin. And thrombocytopenic purpura, a bleeding disorder related to platelets.
Wow, quite a spectrum. So the clinical presentation takeaway. Recognize that typical two-phase pattern, initial subtle lesion, then delayed swollen nodes, add on possible general systemic symptoms. And critically, know that list of rare but serious atypical forms, remembering who's at higher risk, like immunocompromised patients, or specific routes like eye exposure for paranos.
Precisely. Understand the whole range.
All right, so we suspect CSD based on the story and the exam. How do we actually confirm it? Let's look at investigations.
Well, your notes really stress that the diagnosis starts with that clinical picture, plus the history, especially the cat contact. Lab tests are mainly there to back up that suspicion and, importantly, help rule out all those other things on the differential list we talked about.
Okay, so what are the key lab tests mentioned in the notes?
The main one is serology blood tests looking for specific antibodies against Bartonella henselae. The notes mention IgG antibody titers over 1.64 being supportive. PCR testing, which looks for the actual bacterial DNA, is also listed as a tool.
Is imaging, like scans, always needed?
No, the notes specify that imaging ultrasound, MRI, CT is usually kept for when you suspect complications or if you're worried about other organs being involved, not routine for a simple case.
What about just bog standard blood tests? FBC, ESR.
Basic bloods might show a mildly raised white cell count leukocytosis and a raised ESR, which just indicates inflammation, but they're very nonspecific. They don't point directly to CSD.
And for those really tricky cases or the severe ones?
Yes, the notes mention tests for specific situations. A lymph node biopsy might be done, especially if you need to rule out something serious like lymphoma, or if the diagnosis is really unclear.
Okay.
If there are neurological signs, a CSF analysis lumbar puncture is listed to exclude other causes of encephalitis. And an EEG might show general slowing if there's encephalopathy.
Right. So investigations takeaway, clinical story plus cat history is king. Labs like serology and PCR confirm it. Imaging is for complications. And more invasive stuff like biopsies or CSF taps are for ruling out other serious conditions or checking severe presentations.
That sums it up well.
This leads us nicely into management. Now, looking very closely at the specific revision notes you provided, the section labeled management is, well, it's structured a bit differently than you might expect, isn't it?
That's absolutely right. It's interesting. The notes under the management heading actually go back and repeat the detailed description of the clinical presentation.
Yeah.
They cover the initial lesion again, the lymphadenopathy, including the potential for separation, the systemic symptoms, and that whole list of severe and atypical forms we just went through.
So if we're sticking strictly to what's in these notes, the management section seems less about listing specific treatments, like which antibiotics to use, and more about what, prompting you to think about the presentation again.
Exactly. It strongly implies that for revising from these specific notes, the key insight under management is understanding that the treatment approach depends entirely on how the patient presents.
Right.
So it suggests, supportive care might be enough for typical, uncomplicated cases, while the severe or atypical forms would obviously need specific interventions, even though those exact interventions aren't detailed right here in this section of the notes provided.
Okay, so that's a really important point about how to use these particular notes for revision. Under management, the focus is Recognize the spectrum of disease, because that dictates the general management strategy. Acknowledge the notes don't list specific drug regimens here.
Precisely. It's about understanding the clinical variations guide the approach.
Okay, understood. Finally, let's look at prognosis and complications, and crucially, prevention. What's the general outlook for someone with CSD?
Generally, the prognosis is actually pretty good. Your notes state most people recover fully, without any lasting problems.
That's good news. What about those swollen nodes, though? Do they just vanish quickly?
Patience is needed there. The notes mention that the enlarged lymph nodes can take weeks, sometimes even months, to get back to their normal size.
Right, so persistent nodes don't necessarily mean something's still seriously wrong.
Not necessarily, no. It can just take time for the inflammation to fully resolve.
We talked about severe forms. Are those the main potential complications?
Yes. Complications are rare, thankfully, but they can be serious when they happen. Things like abscesses forming in the nodes that might need draining, the infection spreading to organs causing damage, or those neurological problems like encephalopathy or neuroretinitis.
And linking back again, who's more likely to get these rare complications?
Absolutely, your notes reiterate this. Severe cases and complications are significantly more likely in immunocompromised patients. It circles right back to that key risk factor.
Okay, so mostly good news, but be aware of rare, serious issues, especially in vulnerable groups. Given all this, how can we actually prevent cat scratch disease?
Your notes list several key prevention tips. Firstly, tackling the source. Making sure cats, particularly kittens, are treated for fleas is really important. Fleas play a big role in the cycle.
Right, flea control. My cat hates it, but sounds essential. What else?
Try to avoid traumatic injuries from cats' scratches and bites, especially from kittens, who can be playful but are higher risk carriers. Easier said than done sometimes.
True. And if you do get scratched or bitten,
wash the wounds straight away, thoroughly, with soap and water. This basic hygiene can help remove bacteria before they get a proper hold.
simple but effective. Anything else?
Yes, one more point. Try to prevent cats from licking any open wounds or cuts you might have. Again, because the bacteria are in their saliva.
Makes sense. So prevention takeaway. Focus on cat factors, fleas, avoiding scratches, bites, especially kittens, and good wound care if you do get injured.
That's the core message.
And that brings us pretty much to the end of this deep dive into your MSRA revision notes on cat scratch disease.
We've covered quite a bit of ground, haven't we? From the definition and the bacterium, how it infects via lymphatics, the risk factors, that huge list of differentials, the typical and atypical ways it presents, how it's investigated, the specific focus of the management section in your notes, and then prognosis, complications, and prevention.
Yeah, we really tried to follow the structure of your notes, aiming to make it high yield and hopefully a bit more memorable for your revision, framing it as a journey, pulling out those key insights.
Hope it helps solidify it for the exam.
So maybe a final thought to leave you with as you carry on revising. Considering how common pets are, how easily you can get a little scratch. It's quite striking, isn't it? How something so seemingly small can lead to this whole spectrum of illness.
It really is. And it underlines how important those really basic things, like just washing a wound properly and promptly, can be. Simple public health, simple hygiene, preventing something that could potentially cause weeks or months of trouble.
A great reminder of how small actions can have big impacts on health.
Absolutely. And hey, if you have other topics, other revision notes that are proving tricky, do send them over. We're always happy to do another deep dive if it helps.
Definitely. And don't forget those other resources for your MSRA revision journey. Check out pastmsra.com.
And also freemsra.com. Both really valuable tools designed to help you prepare.
Well worth looking at. Okay, thanks for joining us for this deep dive today.
Yeah, keep up the great work with your revision. Keep learning. Keep connecting those dots.
And best of luck with the exam.